Both, yes.
Perfect. Thank you. So, first of all, those who don't know me, I'm from Ahmedabad, India. And Ahmedabad is the capital city of the most western province of India, that's Gujarat. A bit north to Mumbai, a bit southwest to Delhi. And more so, it's popular because the birthplace of the father of the nation, Mahatma Gandhi ji. And those who visit India, they don't fail to visit Asiatic Lions in Gujarat. And for the last couple of decades, Prime Minister Narendra Modi had made this place very popular, and it's his birthplace and his constituency. Kevin has visited Ahmedabad for a few times, and he and his team from Cincinnati has been conducting mission trips in the charitable foundation where I also work. And it seems that Kevin enjoys his mission trip with, and we all are very happy with the services they are offering. Thanks, Kevin. And way back, he could also visit our comprehensive brachial plexus clinic, which we have been running for last now 15 years. And we have good exchange of thoughts. This year, I'm organizing POSICON, that's annual Pediatric Orthopedic Society India's meeting, and our next guest is Dan. Dan, thanks for accepting our invitation, and we are looking forward to have you with us. And those who all, I invite you all to attend this meeting.
Thank you.
I'm thankful to this guy, Federico Canavesi. Federico and me were co-fellows at SickKids, and he introduced me to Francisco. And I hope this relation goes on for exchange of knowledge for many, many years from now. So thanks, Federico and Francisco. Coming to the topic, now if I present this X-ray of a 7-year-old girl with completely toppled off radial neck fracture, and or something like this where the radial head is completely off on the front, and if I propose these options, I'm sure that most of you would consider doing intrafocal pinning because a very severely displaced radial neck fracture, or some of you might do an intrafocal assisted pinning and followed by an antegrade tense nail to perform a Matizou technique. And we take open reduction as the last resort because there is huge association of complications. But very few of us would think that this fracture pattern is amenable for close reduction. And you are right, because the literature suggests when this Judate 1 and 3, when the angulation is less than 30 degrees, this can be conserved because this fracture has remodeling potential. But when it is type 3, that is moderate angulation between 30 and 60 degrees, close reduction methods comes in play. But when there is severe displacement like Judate type 4, either percutaneous assisted reduction or open reduction has been advocated. There are different reduction maneuvers described in literature, right from Peterson maneuvers to Israeli technique to Nahartosh and so on. But all these methods were successful in treating Judate type 2 and type 3, but none of them uniformly achieved complete reduction in severely displaced radial neck fractures, that is type 4 A and B. And so what is OrthoKit's technique? Actually, this is the conglomeration or modification of the maneuvers previously been described for most severely displaced radial neck fracture. And if you apply this maneuver in a particular chronology, you can reduce the severely displaced radial neck fractures type 4s without any instrumentation. And that's what OrthoKit's technique is. So I'm going to explain to you this. Let us see this technique at a glance through this animation. The first step is to see the radial head in profile. And to see this, you have to maneuver or rotate the forearm under image intensifier. And you should be able to see the radial head as a rectangular piece. And this is the position where it's a pre-injury position of the forearm. And then varus force is applied by assistants and a longitudinal traction by surgeon, which decompresses the lateral recess. And with a thumb pressure, the radial head is pushed, which turns a type 4 to type 3 Judate. And then you should perform a simultaneous flexion pronation maneuver, which reduces this radial neck completely over the metaphysis. And one can check the stability of this reduction in flexion and extension in both the planes. And if it remains stable, then you can just apply a plaster in mid-prone position and you can avoid any instrumentation. If we see the biomechanical basis of this technique, when we flex the elbow, it obliterates or tightens the posterior capsule. And when you pronate and flex simultaneously, the annular ligament, accessory collateral ligament, and lateral radial and ulnar collateral ligaments become tight. And this tightened ligaments places the radial head in its position. And we have seen that when we supinate this reduced radial head, it gets translated. And so that pronation maneuver is extremely important. So if this technique is performed in this chronology, we could reduce all the type 4 radial neck fractures without any instrumentation. Let me demonstrate you this technique in a real time in a 6-year-old girl with type 3 radial neck fracture. And we need to position the child on the radiolucent table. As you can see here, the child lies on the edge and the forearm should be on the radiolucent table. An image intensifier comes from one side. And one should first try to see the forearm under image intensifier so that they can visualize the radial head as a rectangular piece. This is the radial head in profile, and you should perform all the further maneuvers in this position of the forearm where the radial head looks like a rectangular piece, as you can see in the index image intensifier image in a moment. So this is the position you should remember when you perform your further maneuvers. The third step is to give longitudinal traction, which surgeon gives, and a counter traction is given by the assistant from the top. And then your assistant should give varus force. This combined longitudinal traction and varus force decompresses the lateral recess and makes place for the radial head to pass between the capitellum and the metaphysis. So you can see this. And once you do this, you locate the radial head with your thumb on image intensifier. In some chubby children where it is difficult to locate, we see the lateral view of elbow to make sure that your thumb lies on the radial head. And then you push this radial head, which will convert a type 4 Jude to type 3. And once it is partly reduced, one should do the flexion and pronation maneuver, which is done simultaneously. And then you will see the radial head is reduced anatomically. And once it is reduced, you check the stability of reduction in both flexion and extension in AP and the lateral plane. And for that, you should turn the extremity externally as we do in stable supracondylar fractures and range the elbow through the flexion extension and make sure that the radial head is not moving. And once this reduction is stable, you can apply plaster in mid-prone position. So if we see the radiologic correlation, this is the X-ray of child which I shown before. After longitudinal traction and varus force and thumb pressure, we could convert it from type 4 to type 3. And with the flexion pronation maneuver, we could reduce it completely anatomically, and it was stable throughout, and we avoided any interfocal pin or Matthews tense nail. And this is a year follow-up. As you can see, it's completely reduced and child gained full range of motion. Let me show you another example. This is again a 10-year-old boy with completely toppled off radial neck type 4B. Again, we could reduce it with the same technique and we did not require any instrumentation. Now, this third example is a daughter of my orthopedic colleague, and she had very severe injury where the radial head was lying in the front, as you can see. And we could employ the same technique, and we locate the radial head well, and this is how we could reduce it. We see sometimes radial neck fractures in very young children where radial head is not ossified. One can do an arthrogram, and it should be followed by the same technique, and you can reduce it very well, as in this case. Where this technique may not work, what we have seen is when the injury is more than 7 days old, the radial neck gets a bit stuck. Although in couple of instances, I have used a blunt K wire to do an osteoclysis, and I could successfully reduce them back. But in my experience, when injury is older than 7 days, many a time we may fail. And the one where the radial neck fracture is associated with elbow dislocation or a Jeffrey type of elbow dislocations, their ligamentotexis has been disrupted, and there this close reduction technique may not work, and you may have to adhere to other modalities of fixation. However, I receive examples from my colleagues and my ex-fellows. For instance, this bilateral radial neck fracture child, who especially on the left side had a complete dislocation with avulsion of collateral ligaments and completely topple of radial neck. He could reduce it with this technique after elbow reduction. And he found radial elbow pretty stable after this technique, and he conserved it. This is 3 months follow-up of this injury. And surprisingly, this girl had full range of motion at 1 year follow-up in both flexion, extension, and pronosupination. However, I do not recommend, I suggest that you might need to fix the radial head, and close reduction may not work completely in dislocated cases. This technique has been published in Indian Journal of Orthopedics in 2020. And those who want to look at it in greater details, subsequently we could publish it in JBJ's Essential Surgical Techniques in 2022. So take-home message is isolated, severely displaced radial neck fractures, that is Jude type 4, without any associated elbow dislocation, can be treated by orthokid's technique without any instrumentation. And unstable or neglected cases should be reduced, and they might need instrumentation. So thank you very much for your patient listening.
Wow, Paul, that is fantastic. What an eye-opening presentation, actually, for those of us who treat radial neck fractures. And I will tell you that I've not had the same success in reduction, and I'm anxious to try your technique. There's a couple questions that have come up, and I think the main one for me as well, and Scott suggested this, is do you use an arthrogram when you're doing your reductions? I find that usually is helpful, especially when you have that upside down radial head fracture that it's very difficult to visualize, particularly in younger kids.
Yeah, so you do the arthrogram through a conventional posterior approach and try to move the forearm under image intensifier till you see a rectangular piece of radial head. And that's the position in which you will do all the further maneuvers. The problem is many a times people try this technique and they do not visualize the radial head in its profile, and they start reducing. When you kind of pronate the forearm more than it should be, then it already obliterates the space between joint, the capitulum and the metaphysis. And the moment you bring it in pure profile, the radial head moves in like a disc. We push in the computer. So it's very important to see the radial head in profile. It becomes difficult when the radial head is not very ossified, so you need to have a very good arthrogram. But it is fairly straightforward when you see in older children where radial head is ossified.
Does it matter if the head is anterior more, lateral more? Because you're basically positioning it wherever it may be to get that rectangular profile.
Yeah.
Does that affect the reduction in any way?
I would say now we have done about 50 cases collectively with my friends, and about 90% times this is anterolateral. So more anterolateral. The one which I show you, my friend's daughter, she was pure anterior. So there you have to spare some time to locate the radial head even in lateral plane on your image intensifier, and properly position your thumb over it. And there you try to push the radial head still when you are in extension. And once it is placed, then you do the pronation and flexion maneuver. But in most of the times, it is more lateral than anterior.
And the video you showed, basically you need 3 people. Is that correct? Or do you think you can get away with 2?
Oh yeah, you need 3 people, because the surgeon would give longitudinal traction with the right hand, and the thumb pressure. The surgeon will use this. The nurse will give counter traction, and an assistant will give varus force. So 3 people are required. Yeah. And the person who's showing image intensifier, so IIT technician is one more.
So another question for me is, we've seen, the standard sort of party line, right? The recommendations in the literature, 30 degrees is fine, right? We've not seen that to be the case. We see, Scott, stop me if I'm over speaking, but we have seen these subtle malunions of like 30 degrees, or even slight translations of 5 millimeters, and they get this sort of cam effect of the radial head, and it pops out at certain, I feel like it's an intra-articular injury.
I agree.
And an anatomic reduction is really important.
It's mandatory.
Yeah.
So I agree with you, Dan. If you see, John Wedge published a paper way back in, I think in 90s or 2000, from sick kids, and they have found that the translation of more than 2 millimeter leads to a cam kind of impingement, and the radius does not move fully in the radial notch of ulna, and those patients always had a problem of rotation restriction. The Jude says that it's angulation, but if it is angulation of 30 degrees with more than 2 millimeter translation, that patients may have restriction of forearm rotation terminally, and so we should try to reduce it as anatomically as possible. That's what I prefer.
Yeah, it's interesting because it is such a complex joint. It's not just a radiocapitellar joint, it's also a radial ulnar joint.
Yeah.
And so you need to interact with both surfaces in a way that, and keep in mind that the radius will spin and then flex extend, right? Or otherwise flex extend and spin, right? So there's
another observation then I have seen is some colleagues, they have just applied plaster in supination in angulation of about 30 degrees, and when they bring the children in follow-up, they have found more angulation and translation. So my advice to all the fellow colleagues is, in supination, the ligaments are lax and it will give more space for radial head to move. So even though you don't attempt a close reduction, apply plaster in mid-prone position so that radial head will not move. You understand what I mean? Because if you apply plaster in supination, you are making those ligaments lax, and that radial head may drift a bit or in follow-up. And so better you apply it in mid-prone, and they never lose movement. They gain full range of motion.
So the corollary to that is, if you have a elbow dislocation with a radial neck fracture, but you manage to get it reduced, are you more likely to pin those because of the lack of soft tissue stability?
Yeah. So I personally have not been successful to manage elbow dislocations with radial neck with this technique, but 2 of my colleagues and fellows, they sent me the follow-up pictures. One of them I included in my presentation. but they were a bit stable. On what happens is you can reduce the radial neck, but the moment you extend, the elbow gets dislocated again. So
Right.
unless you stabilize the radial head bell either with a K-wire or a Matazu, I'm not fond of doing tens, a retrograde 10. I would put on K-wire from the extra articular cartilage. But I would say that you need to, fix the radial head when it is associated with dislocation.
Yeah, there's a couple more questions here in the chat. One of
Yeah.
them is how many times would you repeat the maneuver? So if it doesn't work the first time, would you do it again? And then how many times would
Yeah.
you do it before you try something else?
Yeah. So I would suggest that you try 2 to 3 times at least. The reason behind is many times you will see the 2 times you will see the radial head is almost reducing and not 100%, and you come back. And when you are novice to this technique, you should have faith in this technique that this works. And the time it will work, you will get, you'll be very happy that you could reduce a completely displaced radial neck fully. But you should try 2, 3 times. Every time you will see you can put the radial head back more anatomically than before.
Mhm.
And if you are not able to move the radial head, then confirm that you are giving proper pressure. You are not in anterior or posterior to the radial head, confirm it on lateral profile.
Scott, did you have something else?
Just a couple quick things. So I can see really struggling with one that's anterior, right? Because I think because your thumb's going to be in an awkward position. But you'll say sometimes on a anterior head, you'll use a lateral X-ray and then perform the same maneuver. Is that correct?
Yes. So
Yeah.
you look at the lateral and you put your thumb right on the radial head. And there, sometimes you need to rotate the image intensifier, then the arm, and then you will be
And then,
successful.
do you think your technique, just like the metazo, relies on some intact periosteum somewhere?
Yeah, come again, sorry.
Do you think your technique also, like the metazo, relies on some intact periosteum somewhere between the neck and the
Yeah.
head?
More than periosteum, I think it's the ligamentous complex, because I have seen completely displaced radial head. So and we can see there is very thin periosteum would be intact laterally, but more so if it is not associated with dislocation, all the ligaments are intact, and with this maneuvers we are kind of maneuvering through the ligament, making them tight, which helps in keeping the head in position.
And then one more question is, I can see, especially in a difficult case, say on a third reduction, you finally get it, and it's, how do you follow it? Because you've lost your ability to do an arthrogram. So how often do you follow them? Do you get obviously just AP or lateral X-rays? You take them out of the cast and get an X-ray? What do you do in follow-up?
So the patients are followed at 1 week, and we try to get AP and lateral X-rays. For getting a good AP X-ray, you have to maneuver the X-ray bin, and if the position is good at 1 week, we would follow them at 3 weeks. Children younger than 6-7 years, we keep plaster for 3 weeks, and older children we keep it for 4 weeks, and then we remove it. I agree with you that the problem comes where the radial head is not ossified, but there, we just get clue about the whatever ossification center is there. We try to compare immediate post-op film, and it's not that easy when we compare with that radial head is ossified. So I agree with you that.
And then the very last thing, Dan, and I'll stop, is sometimes they don't give a history of a dislocation, right? You can just tell by the amount, you can tell by the amount of swelling, or you get some sense that they're really swollen. What about those cases? Do you leave the option open to do A and or B?
Yeah. So that's a great question, Scott. And I always teach my fellow that you don't just look at the X-ray, but look at the child. What I have seen in isolated radial neck fractures, they have pain and swelling only on the lateral joint line. But when it is associated with dislocation, they have a global swelling. and they have tenderness on the medial as well as the posterior side. So when they have global swelling and tenderness on medial and posterior, I would assume that this might be a dislocation which is spontaneously reduced, and this can create challenge in surgery. So we keep those options of fixation open in those patients.
And Dan and I, in those cases, have actually delayed surgery too. You know, the ones that you're going to take right to the OR, if you take the dressing down and they're ginormous and there's ecchymosis medial and lateral,
Yes,
we'll wait 3 or 4 or 5 days later. It's just an easier operation.
Right. That's right. Agree.
But I will say that I'm going to echo what Dan said. We have not been successful, but maybe we've not been doing it right. And I think what we'll do.
I will share these videos and animation. We do not have faith. Being orthopedic surgeons, we have been trained that all severe needs instrumentation, but try to have faith in this and try a couple of times. The moment you get the reduction, you will become brand ambassador of this technique.
Yeah. Well,
I promise you.
I think the PALMA and others from the way back when of closed reduction of fractures, you know, and they'd be appreciative of this comment. We are definitely going to give it a go.
Mm-hmm. Yeah, and I think this is our first talk that I can recall on PULM about a closed reduction technique. So congratulations on that. Love
Thank
it.
you.
You know, we surgeons don't, it's not as sexy sometimes, but so important, right? So important. All right.
You know,
so
we know
we
one
are-
more comment,
officially-
Dan, real quick. So, you know, when I used to take care of adults, it's super important that when they would dislocate their elbow and you get an X-ray, a lateral X-ray, and it almost looks like they're posterior lateral unstable, meaning the radial head drops from the capitellum. And a lot of times the residents and fellows go, oh my gosh, the patient needs surgery. That's not the case. If you take that adult, put them in pronation, just like you're saying, they can tighten up that posterior lateral corner just enough, and the radial head will migrate in an anterior direction, even in adults. So I think the concept of pronation for this type of injury is interesting. When you think about it, it's fascinating because Montage is the opposite, right? Montage is going to reduce better in supination. This is going to reduce better in pronation. Food for thought. Thank you. That was very informative.
Thank you very much.
And shockingly, we're on time, Scott.
Oh, we have plenty of time to mess that up. Kevin's up next, I think.